Welcome to the SuperPod podcast. I'm Emily Ball from Active Step Foot and Ankle Clinic, and I'm delighted to be joined by Alice Forward, who is one of our advanced musculoskeletal podiatrists who has a special interest in heel pain. She's also been recently published in The Podiatrist, which is the professional journal of the College of Podiatry. Welcome. How are you today?
I'm very well, thanks. How are you?
Good, yeah, not bad, not bad. So tell us a bit about what sparked your interest in heel pain.
So I think it all started when, like any new graduate, when I graduated all those years ago, that you come out and you get given the normal advice of heel pain is cured by calf stretches and a bit of ice. And so for the handful that it seemed to work for, it was great. And then you'd come across those stumbling blocks where anything you thought you would try wouldn't work, and therefore it got to a stage where you really want to help somebody, and quite often they were people that were quite athletic, want to get back to their activity, what they love, and then you just have to find
running and walking.
Absolutely, yeah. And you just want to get them back to the activity that they love, and that's what then sparked me on to really focus on it and learn more about it.
Sure. So tell us about the different types of heel pain.
There are many different types of heel pain, and what you'll often find is that plantar fasciopathy is what's quite often given as a generic heel pain. So as soon as quite often people hear heel pain, and that's what automatically is assumed. There are many
plantar fasciopathy, which previously used to be referred to as plantar fasciitis.
Yes.
Yeah. Okay.
Yeah. So that, yes, is probably one of the most common or the common heel pain that we will see in clinic. But there are many other different conditions, such as fat pad atrophy, which is wearing of the fat pad that sits under that heel bone. Cushiony bit. There is a chance of calcaneal fracture, which again is that heel bone fracture. Bony edema, which again is just a little bit of bruising on the bone as such. Swelling, yeah. There is also, if we come sort of round to the back of the heel a little bit more, then we're looking around insertional Achilles tendinopathy, so that tendon that sits down into that heel bone there. Then we're looking into that, or bursitis or retrocalcaneal bursitis.
Sure, because there's certain sort of medical conditions that can predispose you to heel pain.
Absolutely.
Isn't there? Can you just tell us a bit more about those?
Yep, so certain medical conditions, so anything essentially that will affect tendons, fascia, connective tissue are all...
Like rheumatoid arthritis?
Yeah.
Yeah, okay.
And they will all have a bit of an impact on how lax and how pliable, yeah, and the collagen levels of collagen in the structures.
Okay, so with plantar fasciopathy being the most common cause of heel pain, can you just tell us what some of the classic symptoms of that might be for anybody that's watching that's maybe suffering with pain in their foot? Well, heel specifically. Yeah. Can you tell us sort of how that would classically present?
Yeah, so plantar fasciopathy, one of the most common symptoms are the first thing in the morning, you get out of bed and you are hobbling. That is
so that
first step pain. Everyone always says, "Oh, I try and get out and try and go to the toilet first thing in the morning," and it's hell. And that's when you get that horrid. And the same applies sort of later on in the day. If you've been on your feet all day and you go to sit down in the evening, you go to stand up and you get that horrid pain in the heel.
How does it feel?
Sharp, real dull ache. Can then throb then, but what you then often find is as you continue to move, as it starts to warm up slightly, you get less of that discomfort. So although you'll hobble for those first few seconds, bit by bit that will start to ease.
And which bit of the heel would it classically, would you feel that?
So you feel it sort of right in the sort of inside of your heel here, which will then, and sometimes you get it sort of more around the heel as well, but you'll classically feel it right just behind the arch.
Yeah, we call it spot X, don't we? So it's a very sort of specific point. If you shoved your thumb in it, you'd probably jump out your skin, I would have thought.
Absolutely. Have to apologise before we do that.
Yeah, we always apologise to our patients before we shove our thumb in their heel. Okay, and what are some of the risk factors? So from the caseload that you see in clinic, and you obviously see quite a lot of it, what would you say the sort of classic risk factors leading up to someone developing that condition would be?
Yeah, so it varies again from person to person. No two are the same, but classic things, obesity or higher BMI do play a large factor. That's 70% of cases will present with somebody that's overweight.
Okay.
So
that's
quite a high risk factor. Other factors will include their level of activity. Quite often we will see what we call the too much too soon effect as such, especially with lockdown as it has been. We have seen people...
And New Year, of course.
Absolutely.
A double whammy combination, lockdown and New Year's resolutions.
Yeah. Everyone's starting, everyone wants to get fit again, everyone wants to be outside, which is fantastic. But if you go from leading a desk-based life to when wanting to run 5K and going out and running that 5K, we might be in trouble, and that's sort of where we...
sort of overloading.
Definitely.
Yeah. And why is that level of overloading an issue? What's the kind of physiological effects that you would see in the fascia?
So as we sort of overload that fascia, what we'll see is start to pull against, essentially if you have anyone that's, again, another predisposing factor is sort of biomechanical issues or biomechanical presentations. So pronation or even high arched. So anyone's pronated, so slightly sort of more flat-footed, and again, same on the other end of the scale, someone's quite high arched.
And you're referring to maybe the extremes.
Yes,
yeah,
absolutely.
I think most of us roll in a bit, don't we?
Yeah, absolutely. Yeah, I think absolutely. But what you'll find is that as you hit those extremes, you start to increase load on those structures. As that, you get that increase in, we go past that point of optimum load, shall we say, and then
it becomes pathological, which is problematic.
Yeah.
Okay. Cool. So for someone that's suffering with plantar fasciitis or plantar fasciopathy, as it's now known as, what would you recommend would be the sort of first line treatment that they should try?
So I think the best thing that you can try initially is some isometric exercises.
And what's that? Because isometric's quite a medical term,
yes,
sort of technical term.
So just some nice controlled body weight, heel raises, but holding those positions.
So getting up onto your tippy toes.
Getting up onto your tippy toes, coming up, keeping the weight across the ball of the foot, across the big toe as such. Quite often you'll see exercises where they roll a towel up underneath the big toe as well. That is an alternative, absolutely. But holding that position as opposed to doing many repetitions.
Sure, and how long would you hold it for?
Roughly around 30 seconds. But you need to repeat that. So you repeat that a couple of times, but you have to be repeating it throughout the day as well.
Okay. Good, that's good advice. And I think there's a myth certainly among the public that this plantar fascia condition is caused by inflammation. What would you say about that?
Inflammation will be present in some of the cases, but not all.
Okay.
And that's what sort of studies tend to show, which is why we've changed why the terminology has changed. So we've gone from plantar fasciitis. Itis meaning inflammation. And we've gone along the lines of plantar fasciopathy, therefore meaning just there is an issue with the plantar fascia.
Sure.
It's more a generic term, because it isn't always the case and it isn't always present.
Okay. In fact, anecdotally from my experience, I would say the earlier someone comes in with it, the more likely it is to have that sort of inflammatory component.
Absolutely.
But unfortunately, most of the people that you and I see have probably had it a little while and tried a few things before they actually present in clinics. So they tend to be certainly more
definitely
prolonged in nature.
Yeah, lots of them have years and years. And I think we're all culprits for it, thinking that as soon as you develop a pain, that oh, it will go away. I've just done a bit too much as I rest it a little bit. But we know that rest over a period of time can be quite detrimental.
Sure, so you wouldn't recommend rest necessarily?
No, not complete rest, definitely not. Obviously has to be a little bit of an element. If you are someone that's normally quite active, you will have to rein that activity in slightly.
So modifying the amount
exercise.
of time you're spending on your feet or the activity that you're doing.
Absolutely.
Sure.
Yeah.
So if you're running, I don't know, let's just say you're running 10k a week,
Yes.
And you've developed plantar fascia issues, what would you say to somebody? Should they stop running, or should they sort of just reduce it somewhat?
I would say initially reduce that back, dependent on how long they've had it. If it's something that's very new, bring that right back so you're running a couple of kilometres, but more of a conversational run as well. So we're looking at sort of rate of perceived exertion around that 5 to 6. Conversational, nothing too strenuous. If it's still then niggling, then we need to sort of take a step back and just continue with some walking, and that's when you'll be.
So your suggestion is you need to almost reduce the cumulative load of that activity.
Yes.
To reduce the amount of stress being placed on the plantar fascia. Yeah. And if they're still getting symptoms, then there's a good chance they might need to stop that activity and actually just focus on what they can tolerate at first, and
Absolutely.
then build that back up.
Slowly build it.
Yeah. At what point would you suggest somebody actually sees a professional like yourself?
I would say as soon as possible. Only because we know that the longer you've had it, unfortunately, it's quite often that the longer it will take to treat.
Sure.
The sooner that you come in, the likelihood, the more load that you can tolerate. And so we will be able to assess very quickly what you can tolerate and what you can't, and get you on a program that will then progress you forward and get you back to the activity that you love.
Okay. And what other therapies? Okay, let's strip that back a little bit. There's loads of therapies for plantar fascia issues, isn't there?
Masses.
In your experience, what is the optimal protocol for managing somebody that's got maybe a long-term condition of heel pain or plantar fasciitis?
So in clinic, if somebody were to come in with chronic heel pain, we would initially, it's a combination essentially of therapies. Now we only use evidence-based practice, so we've looked at the evidence and we have found that this is what works best for us. And we start people off on what we call a progressive loading program. And what that involves is we determine what level of load your plantar fascia can tolerate. Once we've determined that, we can then produce a program that will then gradually load that tendon as you become slightly more tolerant.
And that's a combination of maybe specific exercises.
Yeah, specific exercises, and then increasing to plyometrics.
And what's plyometrics?
Plyometrics, jumping. So lots of springs.
And running activity is of course a plyometric, which
Absolutely.
would be obviously the goal for some people.
Yeah. So so slowly build people back up to whatever exercise that they want to get back into, essentially. But again, based on the individual person. In combination with that, we will then use what we call shockwave therapy.
Okay.
And what that involves is a lovely treatment.
It's quite painful, isn't it?
Yeah, it does. Well, it's uncomfortable at the time, but it poses a lovely perk that it can have a bit of an analgesic effect, so give you a bit of a numbing feeling, which then actually will help long term in terms of we can get you moving along that load program a little bit quicker. The idea behind it is that it will accelerate that healing process. So essentially sort of pummels the area using a shock wave or a sound wave that penetrates those tissues.
I'm thinking hammer gun.
Yeah. Sounds a bit like a pneumatic drill.
Quite noisy.
But it poses wonderful benefits, and so we can move people along that program quicker. It will inflame the structure slightly, but actually because of that, it's bringing with it a lot of remodeling, regenerating properties. That
getting all those healing factors to the site of injury.
Absolutely, yeah. And And so we will always use that in conjunction with the exercises. On its own, has its place, but you won't progress without the loading.
So you're saying that if you use shockwave on its own, you'd probably get some analgesic or some temporary pain relief, and it might feel a bit better in the short term, but without progressively loading the fascia and getting that remodeling and that building of resilience in that structure, it's unlikely to have long-term benefit.
Definitely.
Okay.
Yeah. As well as that, we will use soft tissue mobilizations as well where necessary, ankle mobilizations and taping for the short term. And
tell me about tapings. I think certainly if you were to Google sort of plantar fascia treatments, there's loads of taping strategies on there, but I think the big question for me is, can you explain sort of what the benefits of that would be?
Benefits are predominantly, they're very much the short term. To use it in the long term, you are just, I suppose it's more, I think people would like to use it. It feels quite snug. It's there to immediately sort of to support the structures, decelerate any dramatic movements initially, but it feels quite snug around the foot. And I mean, psychologically in itself is quite nice.
So it's not going to hurt?
Absolutely not.
And it's going to potentially kind of support the foot in a position maybe that's going to reduce some of that
tissue stress.
That tissue stress on the fascia.
Yes.
Okay.
Yeah.
And is there any other sort of adjunctive therapies that you might combine with plantar fascia treatment?
So do lots of strengthening work, again dependent on the structures that may be involved. So what we'll have a look at is we would assess the way that you're moving, and we're not just focused on the foot itself. So as much as it is a key component, we want to also look at the upper body and start to see what other structures we need to start addressing that are contributing to that overloading of the structures.
Now, a lot of people with plantar fascia issues will be asking sort of what's the best type of footwear? Should I be wearing any kind of supports or gel inserts or orthotics?
Yes.
What would be your advice on that?
I would say, so with orthotics, they definitely have their place.
Can you just explain what an orthotic
is a device that will be inserted into the shoe. What the orthotic does, it will address load management or abnormal load management and reduce tissue stress on the structures. So the idea behind it is it's there to just, again, decelerate any abnormal movements, motions. So for example, if someone is flat-footed, it's just going to decelerate that motion so we're not dramatically coming down and overloading those.
Sure, so it's going to modify sort of how that person's loading the foot.
Yeah, which we know in the long
away
term.
From the bit that hurts.
Absolutely. So it's very good for that initial short term, medium term, reduction in pain, getting you back to that activity, but also in the long term for prevention. We know that one of the biggest risk factors for plantar fasciopathy is unfortunately previous history of plantar fasciopathy.
Sure, so if you're a recurrent case, you might benefit from something a bit more sort of structured and permanent, maybe sort of, like an insole in your shoes.
Absolutely. So for the long term, that will just help prevent any recalcitrant injuries.
What kind of shoes should you avoid if you're suffering with plantar fascia issues?
Flat based.
Super flat.
Yes, super flat. Gone are the days of Havaiana flip-flops. But so anything that's very, very flat, that will encourage that movement of the foot.
And the sort of excessive
loading
of the fascia,
anything that's not supportive. Again, I suppose anything of the higher ilk as well isn't going to be overly helpful.
But a little sort of gradient would probably be beneficial as well. Yeah.
In the ideal world, we'd all be wearing, trainers and walking boots. And we understand that we have to play around with that somewhat, but it's just finding that sort of healthy footwear, that happy medium, where we can you have a little incline.
I know you've got this super amazing list of stockists and shoe designs and everything that you give your patients.
Yeah.
Which has everything covered from summer footwear, sandals, right through to running trainers and walking boots, right?
Yeah, and we're very lucky where we are that we've got some fantastic stockists around us that will be helpful. We're super helpful with that. So we can always refer patients on to them for advice.
Excellent.
As well.
So, Alice, top tips. So anyone that is or thinks they've got a case of plantar fasciitis or what we call plantar fasciopathy, what's your key message to them?
Key message is the quicker you get on your loading program, the quicker you see somebody about it, the better chance, or the better chance you'll have of resolving it quicker. Yeah, definitely. And I think with the main thing is you look online and you'll see lots of things about stretching. As much again as it can play a helpful part, really focus on getting some of those isometric holds in early as well, and activity modification is key, definitely in the early stages. But if you need any advice on that, then seek help.
And I think the question on a lot of people's lips: any quick fixes?
No. Unfortunately not.
No quick fixes? No
quick fixes, but it's a labour of love. No, unfortunately not. But it is something that can be resolved, but just with the right advice.
And just a final note, so if someone's getting the right treatment, typically how long will they need to continue with that until they see positive results?
So again, it will vary from person to person, depending on how long they've got it. What we normally look at is around anywhere between 6 weeks to 12 weeks. So we're looking around sort of the 3-month area before
sure.
we
And would
start
that be
to
full
see
resolution or just significant improvement?
Significant improvement, yeah.
Okay, so
full resolution.
We're
looking
management after that as well.
Absolutely, and that's the one thing that we always have to make abundantly clear is the loading program that we will give to our patients isn't just for that period of time, and therefore is something that will have to break into their everyday life.
Sure. Thanks for joining us today, Alice. And for anybody that's been suffering with plantar fasciitis or heel pain, I'm sure you would have found that hugely beneficial. I look forward to seeing you again on the next episode. Take care of yourselves and your feet.